Hello, everyone, and welcome to Arthritis Talks. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. Thank you for joining us tonight. While we have come together for this event from many different places, I would like to acknowledge the land on which I am located on and which our Toronto office stands. That is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I am grateful to have the opportunity to live and work on this land. Arthritis affects women and men differently. 1 in 4 Canadian women is living with arthritis, compared to 1 in 6 Canadian men. That's what brings us together today, to discuss how arthritis disproportionately affects women and the challenges that come along with this. I would like to acknowledge that the title of this webinar, we've intentionally used the term women instead of females. This is because some of the questions we've received will be addressing in today's webinar focus on gender and arthritis, in addition to biological sex and arthritis. Our presenter will share more about this and discuss the differences between gender and biological sex when it comes to arthritis and its impacts. Before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen. We'll try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom middle of the screen to access the chat and connect to other participants, as well as the Arthritis Society Canada's chat moderator. If you would like to close the chat completely, just click the red X icon to close out of the window. And we're pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, and you'll see that running along the bottom of the page. Many questions we received in advance did follow similar themes, so we will address those first before going into the live Q&A at the end of the session. Now, before we get started, I want to take a moment to thank our exclusive event presenting partner, Organon, for supporting this webinar. In addition, I also want to thank Pfizer, United Way Winnipeg, and other partners for their financial support of our Arthritis Talks series. Now, let's get started. And first, a very warm welcome to today's expert, Dr. Mary de Vera, who is joining us from British Columbia. Dr. de Vera, can we start by addressing that connection between arthritis and females? Why are females more likely to get diagnosed with arthritis than men?
Thanks. First of all, I would like to thank Sean for the introduction and the opportunity to be part of this webinar. So there are definitely a lot of questions when it comes to arthritis and sex and gender. And what I hope to do today is to answer these questions by describing research that had been done to address them. So first, let's talk about sex and gender. So when we talk about sex, what we mean is biological attributes. So this refers to hormones, anatomy. So these are things that you were born with. And many of us have now filled surveys, whether it's through research or marketing companies. So you will often see the question, or the correct question should be, what sex were you assigned at birth? And then the responses should be female, male, or intersex. So those are individuals that are born with both male and female anatomy. So you would be surprised that there's actually a lot of conflation of sex and gender terms. Now let's talk about gender. So gender refers to social cultural norms. So this is how you identify, and based on beliefs, cultures, and behaviors. So if this were a survey again, the question should be, which gender do you identify with? And the corresponding responses should be woman, man, or non-binary. And I think it's important to make that distinction between sex, the biological construct, and gender, the social cultural construct, because this is the lens to be able to answer these questions. So arthritis, of course, refers to over 100 diseases that are characterized by inflammation in joints or other parts of the body. And many types of arthritis strike more commonly among females than males. And I just want to quickly show you some of the data that we have on this. So this is from the Public Health Agency of Canada, and it is showing the number of Canadians that are newly diagnosed with osteoarthritis every year. And what you'll see is the orange bars represent females and the blue bars represent males. And you will see that there is a consistent trend of the orange bars being higher among females than among males. So let's look at another type of arthritis, this time rheumatoid arthritis. Same thing, this data is telling you the number of Canadians who are newly diagnosed with rheumatoid arthritis every year. And what you'll see in this graph is that there's an even more pronounced difference. So those orange bars are almost twice as high as those blue bars, again, showing that rheumatoid arthritis strikes more females than males. And then just to show that this is consistent across age, juvenile idiopathic arthritis strikes children and adolescents. And here you will still see that sex effect. So that orange bar being higher than the blue bar we're seeing that same trend. So just to sum it up, so yeah, many types of arthritis are more common among females than males. And then you can see these are some of those ratios in osteoarthritis and juvenile idiopathic arthritis, 1.5 females to every male. And then you're seeing much higher ratios when you're looking at rheumatoid arthritis, up to 2 to 1, and even higher with lupus, up to 9 females for every male that will be diagnosed. So now that I've broken down the numbers, I guess the big question is why. So a lot of arthritis are actually also autoimmune conditions. So this is when the body attacks itself and damages its own tissues, its own joints. So there's actually a link with X chromosomes, particularly with females having 2 copies of the X chromosome. So a lot of genes that are associated with autoimmunity, we females are getting a double dose of those genes. So we can blame it on the X chromosome. There's also a role of hormones, particularly estrogen. So there is a connection with estrogen and joint health, with actually many women, females being diagnosed with osteoarthritis after the age of menopause. And that seems to be explained by the drop in estrogen levels. And then you can also think about the effect of menopause on weight. So many females tend to gain weight after menopause, and that weight gain again puts strain on the joints, on the body, which is also increases the risk for osteoarthritis. So a lot of the increased risk can definitely be explained by sex. There's lesser known impacts on gender, and I think this is where some of the work is going. And then again, when you think about gender, it's thinking about some of those social cultural norms. So one potential impact of gender could be work, including those done outside the house or done inside the house, right? When you think about housework, and that's often gendered. So so there's a lot of work that still needs to be done on gender, but I think when you think about the differences, we can definitely look into the biological reasons for these.
That's great. So Dr. Vera, let's move into some discussion about relationships if we could. We've had a number of questions come in about intimate relationships and people who are struggling with their arthritis at the same time. So do you have any advice in this area?
Yeah, and again, I will draw my advice based on research. And I actually want to highlight, put in a plug that the research that I'm going to describe that could provide us some answers to this was actually conducted at the Mary Pack Arthritis Center here in British Columbia. So that's just a picture of the building where TAS BC is on the 3rd floor. So this is a study that was done again in British Columbia, and the title of the study, which I really appreciate because I think it'll kind of tell you the gist of the findings. So spousal support for patients with rheumatoid arthritis, getting the wrong kind is a pain. And this is such an elegant study, and I really want to take the audience through this. So what was done? So 29 couples were recruited, and there was an RA patient and a partner. and the partner was a cohabitating partner, so they lived in the same household. And what researchers did, over the span of 1 week, the patient and the partner received 2 phone calls a day. So one in the morning and one in the evening. And they were asked the same question. So for the RA patient, they were asked their pain. So their morning pain and their evening pain. And then they were asked this, whether they received support from their spouse. And then the partner was asked about what support they gave to the partner who had arthritis. So really simple questions asked, twice a day over 1 week. So just sharing you the results. But before I do that, so one thing that the study did is it really distilled the type of support, and they divided it into 3 kinds. So there's esteem or emotional support. So this is when you convey that the recipient of that support is loved, valued, and accepted. So, there's not really much action associated with the support. It really is just the emotional support. Second type of support that they measured was what they called solicitous support. So this is conveying concern for the recipient. And I think there is also some action involved in this. And then the last type of support, which is really not support, is negative support, which is being critical of or avoiding the recipient. So then the question was, what is the relationship between partner support and the RA patient's pain in the evening? So that's what that question mark illustrates. Really important here is who reported that support, because the perspective of that support is important. So I hope I hope that everybody has followed kind of like the flow of the study. So, so let's unpack the results. So researchers found a decrease in the patient's pain in the evening when there was higher esteem or emotional support from their partner in the AM, in the morning. And this was support as reported by the partner. They also found that the patient reported higher levels of pain in the evening when they received negative partner support. And this one was reported by the patient. And also solicitous patient report, but this time reported by the partner in the AM. So I'm going to say that one more time. So there was higher patient pain in the evening when there was negative partner support reported by the patient, and solicitous partner support that was reported by the partner in the AM. And then one more thing is the researchers found that higher levels of pain may actually lead partners to increase solicitous support to the patient, but that's not necessarily a good thing. So I really want to unpack this a little bit more in that. So yeah, the study found that there was, when the patient reports higher levels of pain, there was increased solicitous support, which actually might lead to a vicious cycle because solicitous support wasn't associated with improved pain. So then it actually would start a vicious cycle where that solicitous support would actually lead to higher pain, which would lead to higher solicitous support and then cycle back to higher pain. So the takeaway message here is that the most important type of support is that expression of love and valuing to patients. It's really that emotional support. The researchers also advocate against expression of criticism of patients. So this is advocating against negative support. But importantly here is just a caution on that expression of solicitous support. So the conveying concern, which really doesn't seem to affect the pain. And it could actually lead to a vicious cycle. The one thing I want to add though is, they put a lot of weight on the partners here. What I want to advocate for is that partners need support too. So partners of patients experiencing pain, including those with arthritis, actually report greater number of medical conditions such as high blood pressure, heart disease, Partners also experience poorer sleep quality. They experience greater distress. And then they also report higher responsibilities at home, so that they might have to take on extra household duties. And they also have higher responsibilities outside the home, so an increase in financial responsibilities. So again, just adding this layer of caution and also advice to consider the support needs of the partners. So I think when I think about this, like, I think, there's the love language. I think it really is important to recognize love language, or in this case, support language, and being able to provide the right type of support to patients, but also recognizing that partners also need support.
Thank you, Dr. De Vera. You used a word there when explaining that study that I just want to pause on for a second, because I think it's important. You used the word solicitous partner support. Could you just make sure you explain that to the audience so that we fully understand the implications of what you just shared with us?
Yeah, so if I go back to that, so I left this here because I think it really is important to distinguish the different types of the support. The solicitous support here is the conveying of concern for patients. So it's like, we're being worried about the patient. And then actually, as I mentioned in the study, it was also associated with like a little bit of action. So it's more worry, and I guess putting the patient's disease at center versus the emotional support. It is just loving, valuing the patient for the person. So I think that's an important distinction.
Thank you. So we have received a number of questions from people who are looking to start a family and getting pregnant. So I know this is an area that you're particularly interested in. So can you provide your insights into what people need to know about pregnancy and childbirth while living with arthritis?
Thank you. And you're right, this is my area of research. So some really honored and privileged to be able to speak to this, especially to those who ask. So what do females need to know about pregnancy and childbirth in the context of arthritis? So I've distilled these into 4 messages, 4 take-home messages. I'm going to break them down one by one. Really important, and I've seen this in this work, is just the knowledge or the understanding of the role of disease activity in pregnancy in arthritis. And I'm going to explain what I mean there. I also want to share as a take-home message is to be reassured that we now know more than ever about the impacts of arthritis medications during pregnancy. And I want to just give a plug to myself, if I could, and to the Arthritis Society, because this is actually work that I've been able to do with funding from the Arthritis Society that I received actually early on in my research career. Another take-home message that I want to give here is to involve your providers, so the role of your rheumatologist and your other healthcare providers before and during pregnancy. And I'm actually going to also explain this using some research data that you are all getting a worldwide preview, because we have not shared this anywhere else. And then to call on your village to support you. So again, speaking to some of the support issues that we talked about in the last question. So I'm going to just take everybody through these points. So first and foremost, so there, I think, is a long-held notion that arthritis, particularly rheumatoid arthritis, improves during pregnancy. So this is actually a recent paper that had synthesized all of the studies that have measured disease activity during pregnancy in rheumatoid arthritis. So they found 10 studies total that followed women with RA that were pregnant and measured their disease activity using lab values and also joint count and so on. And looking at those 10 studies, so they had averaged that 60% of females with RA do have improved disease activity during pregnancy. So while that seems reassuring, there is still 40% that will experience a flare and that will have uncontrolled disease during pregnancy. So this is really important. And again, this is an area of that I pay particular to in my research, because disease activity is associated with adverse reproductive health outcomes of both the mother and the baby. So active disease during pregnancy has been linked to gestational hypertension in the mother, preeclampsia in the mother. So those are very serious conditions. They're also associated with preterm delivery and associated with small gestational age in the babies, and a whole host of other outcomes of the babies. And this is important because I think one of the challenges that we see with arthritis in pregnancies is women tend to stop their medications, prior to getting pregnant or when they're getting pregnant, because again, that notion during pregnancy is to not take anything out of fear of what that would do with the baby. But in the case of arthritis, it is important to have that risk and benefit analysis, because stopping medications endangers the woman to have a flare, have uncontrolled disease, which is itself linked to these adverse outcomes. So the good news is that, again, we now know more than ever how medications impact the health of the mother and the baby. So we have evidence for the safety of many therapies, such as biologics, that can be taken safely during pregnancy. And we've been able to show that they're not associated with increased risks of outcomes of the babies, including work that I've done, including preterm deliveries, congenital anomalies, or infections. So this is a slide that I put just to show that in the last decade, we've also had guidelines for pregnancy, including those from the American College of Rheumatology. So there's a lot of guidelines that healthcare providers can draw from when they're providing counseling about appropriate medications to take during pregnancy for women with arthritis. Also important to share is there's a lot of information out there for patients. Again, distilling some of what we now know about medications in pregnancy. So I point people to the Canadian Arthritis Patient Alliance, who are wonderful partners in my research. And they've created all these resources for parenting and pregnancy, and I highly recommend them. And these recommendations have actually been reviewed with experts, including myself and another colleague of mine, Dr. Catherine Backman, who's done a lot of research on arthritis and mothering. And the other thing I want to point is, aside from information, and there's also communities of support. So another great organization that I partner with in my research is Mamas Facing Forward. So this is a blog created by a woman with autoimmune disease, and it's a community of women with autoimmune disease sharing about pregnancy and parenting. And there's actually like a growing Facebook group where people will go in and share their concerns. So there's a lot of information and there's a lot of support. So that's a second take-home message. And then the third take-home message is the importance of involving providers. So this is a little bit of a sneak peek of research that we've been able to do. Again, I am pointing to the Mary Pack Arthritis Center in Vancouver. And this is work that is led by a colleague of mine, Dr. Nida Amiri, who is a rheumatologist that specializes in reproductive health. And she is director of the Pregnancy and Rheumatic Diseases Clinic over at the Mary Pack. And what this clinic does, it provides counseling, medication review prior to and during pregnancy for females and males with rheumatic diseases. So I just want to show you some of the work that we've done with this clinic. So we actually did a chart review of patients that were seen at the clinic, and we were able to extract information from 237 patients. And at the first clinic, we found that many of them were planning pregnancy, so about 151, but then also many were seen already pregnant. So there are some differences in outcomes between these females. So during pregnancy, we found that those who had gone to the clinic before trying to get pregnant, there was a lower rate of uncontrolled disease and a lower rates of flares. So for example, we had 19.6% uncontrolled disease among those who were already pregnant versus only 2.2% who had gone to the clinic prior to becoming pregnant. And then similarly, in terms of flares, for the women that were already pregnant by the time they went to their clinic visit, there was about 61% rates of flares compared to women who had gone before planning pregnancy. They had a 22.6% flare. So this really speaks again to like that importance of pregnancy planning and involving your healthcare providers. But I do want to give reassuring data. So the important thing is to see someone during pregnancy, because I could share too that at delivery, we actually didn't see any difference in rates of adverse reproductive health outcomes. So some of those adverse outcomes that I told you about that are worrisome with respect to uncontrolled disease activity. So the take-home message here is it's just important to be able to see your providers to receive that guidance and counseling on what medications you should be able to take during your pregnancy safely, so that we can ensure a healthy and safe pregnancy. And just the last take home was, again, calling on that village. So this is just research, not necessarily in arthritis, so just looking at pregnant women and just the importance of spousal support. So again, this was women in the United States that were surveyed about their partner support during pregnancies. So they were asked, can they count on their partner for financial assistance when they need it? Their partner is, whether their partner is affectionate towards them, whether they think the partner will help when the baby comes, whether they think the partner understands how I'm feeling, and whether they think they can count on their partner to be there when I need him or her. So this study found that, low partner support was associated with 90% higher risk of antenatal anxiety and up to a threefold, so 300% risk of antenatal depression. So just evidence on calling on supports, particularly partners during pregnancy. The last thing there, again, there's a lot of weight put on partners, but then just to also advocate for partners. So in our own work, so we were doing research with mothers with rheumatoid arthritis about their decisions that they make during pregnancy. And one of the things that came up from the study is just the involvement of their partners and the care that they receive, not just for them during the pregnancy, but also they wanted to help in our research too. So out of a research that we did with women with arthritis, we were actually able to do an additional study to ask their partners about what it was like to go through a pregnancy, plan a pregnancy, how that impacts their health, what they do for their partners. And the take-home message for that is, they want to be there, they want to understand, they're working hard to understand the disease. It's hard on them too, but it is something that they want to be able to support their partners with. So I spoke a lot about that because it's my favorite topic of pregnancies and arthritis.
Really interesting information and research, Dr. De Vera. Thank you so much. Let's switch it up a little bit if we could and chat about parenting or grandparenting with arthritis. So how can people be the best parent or grandparent while they are struggling to manage their own disease?
Thank you, and that's a great question. Actually, it's a nice segue from planning pregnancies and ensuring safe pregnancies to now you have a baby, you're going to grow a family. How do you be the best mother? So I'm not the expert on this topic, but I do again want to draw on the research that's been done to look at mothering, parenting, grandparenting with arthritis. Again, to provide reassurance, like people have been asking about this question for a long time. So I'm going to take you on a little bit of a history of research. So as far back as 1999, so this is, I think, when we started this emergence of looking at these roles that people are fulfilling while dealing with a disease as painful and as serious as arthritis. So this was a study that was done on how does arthritis influence one's ability to fulfill a parenting and a grandparenting role, and looking at perceptions of mothers, fathers, and grandparents. So this is very gendered, but I also think this is also back in 1999 when we haven't really been as mindful and knowledge about gender. So this was a survey to parents and grandparents with arthritis, particularly ankylosing spondylitis. So I was really glad to see this because I think in arthritis, we generally see a lot of representation from rheumatoid arthritis and osteoarthritis. So it's nice to be able to actually also see other types of arthritis. Again, there's over 100 types of arthritis. So it's nice to be able to see research in those lesser studied types of arthritis. So in this case, ankylosing spondylitis. There was 145 participants, 47 women and 98 men. So ankylosing spondylitis is the one type of arthritis that is actually more male predominant than female predominant. So what did this research do? So again, it looks at patients' perspectives about their roles. So interesting here, so the graph is really small, but the take-home message is actually the direction of the arrows. So what you see on the y-axis is the level of demand, and then what you see on the x-axis is the age of the child. So from the mother's perspective, well, in terms of physical demand, so that arrow is going downwards. So the highest physical demand is when that child is at their youngest, but as the child grows, so the x-axis ends at 15 years old, as that child grows to adolescence, that physical demand lessens. So that's just the take-home message from that graph. So the interesting thing is there's a second arrow. So you will see now this horizontal dotted arrow. So that is the psychological demand. So again, from the mother's perspective, sorry, I'm gonna see my slides. They're really small too. So from the mother's perspective, that psychological burden is actually constant across the age of the child or the children. What is interesting here is there's that little flip there. There's a that triangle, which is what they call a psychological bonus. So this one I was profoundly touched when I read this part of the paper, and I'm gonna read it out loud. So mothers proudly describe their own children as more independent, caring, and sensitive to the needs of disabled people than other children, and considered that these features had arisen from their children's experience of living with a parent with arthritis. Additionally, some mothers believed that they were able to spend more time with their children because they had arthritis. So that was that psychological bonus of being a mother with arthritis, and yeah, just an unanticipated positive effect. So that's the pattern with mothers. So I wonder if people can already guess or anticipate what a pattern might be for fathers. So I will kill the suspense. So this is the graph. So among fathers, this is what the graph looks like. So I know it's small, so I'm gonna take you to like the take-home message. Again, we're looking at demand, physical demand and psychological demand on the y-axis, and age of the child on the x-axis all the way to 15 years. So interestingly, for fathers with arthritis, you have a physical demand that is much lower when the child is younger, and it increases as the child grows into adolescence. So that's like the solid green arrow. So it is going in an opposite trend of the mother's arrow, which is decreasing as the child gets older. And then also interesting here is the psychological demand is also increasing over time for fathers. And then because the study also looked at grandparents, so this is what the grandparents graph looks like. And it actually is very similar to the mother's graph, where you see a decreasing physical demand and a psychological demand that stays constant. So I think it's just really understanding, again, it's the same as like the partner support, understanding the types of support so that, that can be communicated. I think here it's understanding the types of demands so that can be anticipated, because I think when you can anticipate these demands, that's when you can make adjustments. That's when you can, communicate how others can support you. And I think that can also, something that I always advocate for is like kindness to oneself. So being kind, and just recognizing the different types of demands and how these change or what these patterns of demands are. So this was a study that was done in 1999. So again, this topic of parenting and arthritis has long been thought about. So this is a study from a colleague of mine, Dr. Catherine Bachman at Arthritis Research Canada. So in 2007, she did interviews with 12 women living with inflammatory arthritis to ask them about their experiences as mothers. And this will take everybody through really quickly. This is really hard to see, but the take-home message here is that it's a spectrum, right? So they came up with like a framework that goes from one end, sometimes I can, to all the way to sometimes I can't. And then there's categories around how people did it, how they figured it out, but also recognizing the frustrating times and then those times that it just wasn't possible. They just couldn't do it. And again, when you see that things are not linear, that they're a spectrum, and then it's okay to be, sometimes having a figuring it out day, or sometimes having like a frustrating day, to having sometimes a really great day when when an adjustment was made or a hack was done so that they were able to fulfill that role. I think when you see these, it is reassuring. And I think that's an important thing to be able to communicate about mothering, I think with arthritis, and also I think with mothering in general. But I think, recognizing that the physical challenges with having arthritis just, really exacerbates some of these roles. So just the last thing again, this was a more recent study, sorry, that should not be 2007. So this is actually 2021, is mothers' experiences of well-being and coping while living with rheumatoid arthritis. So again, here are some themes that came out from this research. There's the burden and complexity in the mothering role. There's losing control. There's adjusting and letting go. So very much related to that prior study by my colleague. And again, it's just really realizing, appreciating that, things are not going to be perfect, but there's opportunities to adjust. And also, I think just overwhelmingly, that notion of being kind to oneself and just accepting supports and inviting supports.
So thank you for all that great advice, Dr. De Vera. Before we get into the Q&A for this evening, do you have any final thoughts around the topic of sex and gender?
Just some last thoughts. And again, this webinar has been great because it's really primed me to look more deeply into these issues. So, and I want to say too that this is something that the rheumatology research community is really emphasizing more than ever, especially with a disease like arthritis, which is female dominated. So this is the Lancet Rheumatology. They actually had their October journal is dedicated to sex and gender research in arthritis. And this is actually, when I was preparing these slides, I came across this tweet that actually sent me into like a lot of digging. It actually sent me a little bit of a rabbit hole to unpack this tweet. So I'm just going to read it here. So men with RA were treated earlier and at lower disease activity with biologic and targeted synthetic DMARDs with better rates of remission than women, suggesting rheumatologists are treating their male and female patients differently with adverse outcomes for women. So that was really concerning to me. So I think this was tweeted during a conference. So this study is actually not out yet, but I think many of us are going to be looking for that study when it comes out, because this is really concerning when you're looking at potential sex and gender differences in care. But I did find this research that was done in 2012 in Sweden that revealed the potential sex bias in prescribing of anti-TNFs, so biologics, to rheumatoid arthritis patients. So just in a nutshell, at the time that patients were prescribed their first biologic, researchers looked at sex differences across a number of clinical characteristics. What they found was using subjective measures like total joint count or disease activity that are reported by patients, they found that females at the time that they got their first biologic were at higher levels of subjective measures. So higher levels of disability, higher levels of pain. Interestingly, when you look at objective measures, there didn't seem to be sex differences except for CRP, C-reactive protein. And then just the last thing here is that when you look at the measures based on the prescriber's perceptions, there was no sex differences. So there's a lot to unpack there, right? So at the time of starting biologic, subjective measures seem to be higher among females than males. When you look at objective measures, so these are lab values, there was no difference except for CRP, which was higher in males. And then the last thing is the physician-based measures, there was no difference. So then this leads to questions like, the treatment with biologics seemed to start at a higher disease activity for females, when you measure them based on subjective means. So this suggests that there's a sex differences in processing and experiencing pain, because those pain measures are higher for women by the time they start the biologics. And we also need to consider, are physicians considering these differences when initiating treatment? Because if our goal of arthritis medications is to be able to affect disease progression, and we need to get patients on remedies, on treatment sooner rather than later. So we don't need them to be at those high thresholds, which females seem to be having higher of. So this is not my line of research, but this is work that I know that colleagues will be doing, because it's really important to be able to disentangle differences in how males and females experience and report pain, because it has implications for when they'll get started on therapies that could, that will effectively change the course of their disease. So this is, I think, a really important thing to be able to advocate for.
So interesting, Dr. De Vera. I think that actually leads really nicely into some of the questions that we've received this evening. So my first question, piggybacking off of what you just said, so are women more sensitive to pain than men?
It's actually, the data that I just described is actually the opposite. Women may have higher thresholds of pain, which is why, when they're getting their first biologic, that pain score is much higher. So it might be, we might think that men can take pain more, but it's actually the other way around.
And is there any research about specific pain treatments for men versus women then? Things that work for one and not the other?
So I'm actually not an expert in that area, so I think I'll have to defer that question.
No problem. Okay, lots of questions here, so I'll start off here. Some questions about estrogen and HRT, hormone replacement therapy. So I'll ask a few related questions here. Mm-hmm. First off, you touched on this at the beginning, but what do we know about menopause and arthritis symptoms in women?
So I think there is a link between menopause and the onset of arthritis. Again, with the drop in estrogen levels, we are seeing a spike in osteoarthritis presentation. Also, something else that that is associated with onset after menopause is gout. So many people don't think of gout as arthritis. It is actually the most common inflammatory arthritis. And it has a higher risk after menopause because there seems to be a protective effect of estrogen, which again, when it decreases, the risk of arthritis increases. So yeah, there is that protective effect of estrogen that's on the onset of arthritis that is lost when menopause begins.
Okay. And there's a question here about flares and menstrual cycles. Is there any research that you're aware of that would link arthritis flares with cycles like that?
That is actually something that I have not looked at specifically. So again, I'm afraid to comment on something I don't know.
Yeah, no problem. Thank you. Okay, I'm going to switch gears into something that I know you know a lot about, which is an elaboration around different medications during pregnancy. So
yes,
you referred to some of the guidelines. There's a specific question here about if somebody's on biologics, is there a certain time period that they should be stopping their biologics before they become pregnant? Ideally, if you can time it, and or if they do become pregnant while on biologics, are there any concerns to the fetus?
So that's a great question. So actually, biologics are some of the treatments that have shown to be safe when taken before and during pregnancy. So I spoke about research that we've done that was funded by the Arthritis Society, where we showed that biologic use across all trimesters was not associated with preterm births, not associated for small for gestational age, not associated with congenital anomalies. And then, in addition to our work, there's been synthesis of work. So there's now like 2 systematic reviews that have shown the safety of biologics during pregnancy. So it's actually something that I would not recommend stopping. But again, it's something that needs to be discussed with the healthcare provider to be able to come with the regimen to take it safely throughout pregnancy. Because again, it's important to get that disease under control to ensure a safe pregnancy.
And what about if the male partner is taking a biologic? Is there any research in terms of any concern to the fetus in that situation?
So that data is still it's harder to find that link in the data, but again, just the very little data that we have that suggests that there seems to be a link when the male is taking the biologic, but it's less confirmed than the female data. But I think it's just our ability to be able to measure male medication taking and outcomes of a partner. But yeah, the data is reassuring, but it's not as well established as that for female patients.
Okay. In the research you described earlier about partners, there's a question here about, do many of those partners report having arthritis or other chronic health conditions? And then what do we know about how that impacts, their disease trajectory, their ability to support? A little bit more about that, if possible.
But in that particular study, none of the partners had arthritis, and I don't think they measured. I don't think they measured characteristics in terms of comorbidities. So the only condition we know is that the patient had RA. So I guess just speaks about research is great, but a research study is always going to have limitations. So that for the particular research, I think we didn't really get to know much about the partner's history. But I do want to reiterate that there's other research that has done that do show the impacts of being a partner too, and being a caregiver to a patient with pain, including those with arthritis, and some of those outcomes that partners experience, like the sleep disturbance, like the other comorbid conditions, like the distress. So unfortunately, it just wasn't in that study that I talked about where they were measuring partner pain and support.
Okay. That leads nicely into this next question, which is, do you have any advice about how the patient can support the partner?
Oh, that's a really great question. And I guess I kind of have like, also like a bit of a personal response to that as like as a patient myself. 'Cause yeah, I think, when we think about like a partnership where one has a chronic disease and a partner is healthy, I think a lot of the attention goes to the patient and not necessarily the partner. I think appreciating that, partners need support too, and then also appreciating that, the importance of, I guess, asking for the right support, right? So I think when we say support, we say it so almost so loosely, right? But I think, when I go back to the study, there is a specific type of support that, patients need that partners can give, but, sometimes we don't communicate that, right? So I guess it's communicating, and I go back to like that notion of love language. So what is it that you need to feel supported? And then in that study, it was the emotional support. It was being loved for the person, not the patient, which I think was the difference between the emotional versus the solicited support. But I really appreciate that question. And I think it goes with my advocacy for, or just like, like don't blame the partners, like support them too, because they're so important. And I don't think we pay enough attention to them.
Maybe this is going to be a similar answer. We have a question here from somebody who really appreciates their children and their support as they're living with arthritis. So do you have any advice around helping to make people's childhoods more normal?
Oh, wow. Also a great question. I guess, I've had the privilege of speaking with mothers with children with arthritis. And I think one of the things, again, being kind to oneself, and I think being able to like explain the condition. And I think that, you saw that in that study where there was that psychological bonus. I guess it's kind of like, what does normal really mean? I think each house, each family unit has their own definition of normal. And I think just acknowledging that rather than trying to be like, a family that you would see on TV, or like, what is normal. I think normal for your family is, if a parent has arthritis, is explaining that to the child. Like, children are resilient, they're so intelligent. And I think you do see, because that study showed it, but I've also spoken to many mothers saying like, yeah, their child is so sensitive. They have such amazing children. And I think a lot of that is because they were parenting while living with a chronic condition.
Interesting. So we know that more women get arthritis than men. Do we know anything about the disease severity of arthritis in general in women versus men?
Oh, so I think, yeah, in a nutshell, it's not only striking more women than men, but it's also of higher disease activity among women.
And do we know anything about the biology behind that right now, or why that's happening?
It seems to be the same roles of chromosomes, again, and the same roles of genes and hormones. And just the interaction with autoimmunity.
Okay. We have a question here about someone who gets a lot of migraines. So the question is around whether there's a relationship there that you could help people understand.
Yes, there is. There's actually some very recent research that came out of the US that showed a relationship between arthritis and migraine headaches. So people with arthritis have 80% higher risk of experiencing migraines. A lot of that, I think, is a lot of like the symptoms of arthritis and also the manifestations of arthritis, like sleep disturbances, pain, are also triggers for migraine. And then another thing to layer about that is in that particular study, they also found a sex and an age effect. So the highest risk for migraine seems to be among women less than 45. So, it has implications for disease control. So if you can control the symptoms of arthritis, then it might have implications for risk of migraines.
Okay. Are there certain specific types of arthritis that are more common in women than in men?
So I think the ones that I've listed, so osteoarthritis, rheumatoid arthritis, lupus, the connective tissue diseases, and juvenile idiopathic arthritis. I think some of the ones where there seems to be the same preponderance with males and females, psoriatic arthritis, it seems to be more equal among males and females. And then there are some where there's more males than females until after menopause. So that includes gout and ankylosing spondylitis. But in general, when you think about arthritis in general, it is a very female predominant disease.
So there's a question here about how to approach relationships. So it's somebody who's looking into a new relationship, and the question really is, how do you start that conversation about arthritis? Because we know that lots of people think that arthritis is just aches, just pains, that don't necessarily understand it all. So any advice about how to approach that conversation with a new partner or potential partner?
Oh, that's a really good question. I'm just thinking back, because again, we talked to partners of females with rheumatoid arthritis, and I think one of the things that we learn is, again, they're willing to learn about the disease, but sometimes they're not included in those conversations. This might be like a different patient population, because these are partners that are talking about having babies and growing families. So this is a little bit different from like a new relationship. But I guess just my general feeling, again, from talking with those partners is, there's the interest in the person, I think, precedes the interest in the disease, but it actually also supports the interest in the disease. So if they're going to be interested in you as a person, then hopefully they will also be interested in the condition and understanding it, and how that I guess affects the identity. But generally, I think it's the person first, and the disease just understanding how to live with it, or how to love with it. I'm not a disease expert though. I'm not a relationship expert though.
That's okay. You have a lot of great advice. I think my last question here is one that we actually get a fair bit at Arthritis Society Canada. It's a relatively simple question, I think, but the question really is about diseases that affect women, and two in particular, osteoporosis and osteoarthritis. And the question is, are they the same thing?
In a nutshell, no, they're not.
Could you elaborate a little bit about how they're different?
I'm not an osteoporosis expert, so I'll go to osteoarthritis. So osteoarthritis, affects the joints. So primarily your knee and hips, whereas osteoporosis, it affects the bones. So joints are where your bones meet, and then your bones are what supports your body. So I think this is why I think people think they might be related, but it is where that disease is expressing.
Great. So thank you so much for sharing your knowledge with us today, Dr. Vera. We would like to take just a few moments to get the audience's feedback on today's webinars. So for those of you watching on Zoom, you'll see a poll question come up on your screen with answer options. So click on the response that reflects your thoughts. The statement is, I feel more knowledgeable and empowered after attending this webinar. So we'll be sending you an evaluation form when we email the recording and the slides. So if you weren't able to access the poll question, you'll have the opportunity to give feedback at that time. We do use the survey feedback to shape future Arthritis Talks webinars, and we truly value your input. So once again, we are grateful to our exclusive event presenting partner, Organon, along with Pfizer, United Way Winnipeg, and our other partners for their support of this webinar. Keep an eye out in your inbox for more information about our next webinar featuring Dr. Jason Bussa and focused on the evidence around medical cannabis. This concludes Arthritis Talks, Women and Arthritis. On behalf of all of us, thank you for joining us today, and please stay well.